This is MorbiCast, your quick dive into the world of medicine.
Imagine a 12-year-old boy in a busy, brightly lit emergency department.
Right.
He's hyperventilating. His eyes are just darting around the room, tracking threats that aren't even there.
Yeah, it's a terrifying scene.
It really is. He's incredibly agitated, exhibiting this extreme, almost unexplainable terror. But the most striking, the most terrifying symptom happens when a nurse simply offers him a cup of water just to calm him down.
Mm-hmm.
The moment he sees the water, he convulses in absolute panic. He violently pushes it away, gagging, as if he's literally suffocating.
And honestly, it is one of the most harrowing clinical presentations a physician can ever witness.
I can't even imagine.
The medical team in this scenario, they're scrambling, trying to piece together a history from these completely terrified parents.
What, because they have no idea what's happening?
Exactly. The doctors are running through this massive differential diagnosis in their heads. And then finally, the parents reveal a crucial detail.
The dog bite.
Yes. About 2 months ago, he was bitten by a stray dog in their neighborhood.
But the wound was small.
Right, a minor wound. It healed quickly, so, he never received any medical attention.
So today on the deep dive, we are looking at the clinical data, the virology, and the epidemiology behind a disease that literally turns water into a weapon.
It's wild to think about.
We are exploring a stack of sources to decode a virus where the timeline is entirely skewed, where the damage is invisible until the absolute last second, and where the symptoms look less like a medical chart and more like, something out of a centuries-old horror story.
Right.
We're looking at rabies.
And it is a fascinating, if intensely sobering, stack of sources we are pulling from today.
Definitely sobering.
We have everything from historical epidemiological data to highly granular virology reports, modern clinical case studies, and public health protocols.
So our mission today for you listening is to trace this virus's journey.
We're going to track it.
Exactly. From that fateful dog bite 2 months ago, through its completely silent spread within the boy's body, all the way to this current neurological crisis in the ER.
And if you're listening to this and you've ever, say, interacted with a stray animal or found a bat in your house.
Oh, man, the bat in the house.
Right. This is going to completely change how you view those encounters.
Totally. But before we get into the biological mechanics of why this 12-year-old boy is exhibiting such alarming, almost theatrical symptoms, we need to understand the adversary here.
The virus itself?
Yeah. What exactly entered his system 2 months ago, and why does this specific pathogen carry such a heavy historical shadow?
Well, fundamentally, rabies is an acute, progressive viral encephalomyelitis.
Okay, let's unpack that medical jargon.
Sure, in clinical terms, that just means it is a viral infection causing severe, rapidly progressive, and ultimately fatal inflammation of the brain and spinal cord.
Fatal inflammation, got it.
But from a historical perspective, this disease has haunted human consciousness for thousands of years. It's actually one of the oldest known infectious diseases.
Wait, really? How old are we talking?
We have records of it in the Mesopotamian laws of Eshnunna from roughly 1930 BC.
1930 BC. That is incredible.
Yeah, and those laws explicitly stated that if a dog showed signs of rabies and the owner failed to keep it secured and it bit a person who subsequently died, the owner was heavily fined.
So nearly 4,000 years ago, long before germ theory, long before anyone knew what a virus even was, humans had already connected the erratic, aggressive behavior of the animal directly to the inevitable, terrifying death of the victim.
Exactly. The causality was so stark, so absolute, that it was codified into ancient law.
Wow.
You see it across cultures, too. The ancient Greeks had a special deity, Aristeus, whose primary function was just to protect them from rabies.
They had a dedicated god for it. That says a lot.
It does, and the word itself, rabies, derives from the Latin word rabere, meaning to rave or to rage. It has always been associated with madness.
And because of the symptoms.
Right. And because it was so uniformly fatal, it shaped our early understanding of infection and immunity. It was actually the subject of one of the most famous and, frankly, most perilous milestones in medical history.
We're talking about Louis Pasteur.
Yes, Pasteur's development of the first rabies vaccine in 1885.
The Joseph Meister case. I remember reading about this in our sources. Meister was, a 9-year-old boy who had been severely mauled by a rabid dog.
Bitten something like 14 times, yeah.
And Pasteur treated him.
He did, but the context is what makes it so astonishing. You have to remember, Pasteur was a chemist and microbiologist. He was not a licensed physician.
Oh, right. I forgot about that part.
He had been working on a rabies vaccine using desiccated or dried spinal cords from infected rabbits. He had tested it on dogs, but never once on a human.
So when this mauled kid shows up at his door...
When Joseph Meister was brought to him, Pasteur faced a profound ethical dilemma. If he did nothing, the boy would almost certainly die a horrific death.
And if he tried his experimental vaccine and the boy died anyway?
Pasteur could face ruin. He could potentially face criminal prosecution for practicing medicine without a license and literally killing a child.
Talk about high stakes. He was essentially injecting a child with pieces of the very pathogen that causes the disease, hoping he had weakened it enough not to kill him, but kept it strong enough to trigger an immune response.
It was a massive gamble. But he proceeded. He administered a series of increasingly virulent injections over several days.
And it worked.
It worked. Just Meister survived. It proved that you could actually intercept an infectious disease after the exposure but before the onset of symptoms.
Which is incredible. But despite Pasteur's breakthrough over a century ago, the epidemiology in our sources paints a really grim modern picture.
Unfortunately, yes.
Like, we aren't talking about a historical curiosity here. We're looking at a disease that still causes an estimated 59,000 human deaths every single year.
Predominantly in rural areas of Asia and Africa.
59,000, that's so high for a preventable disease.
And epidemiological experts widely agree that 59,000 is a massive underestimation.
Really? Why is that?
Well, in many of the most heavily affected regions, diagnostic facilities are scarce. People who die at home in rural villages are simply never recorded in official health registries. So the true global disease burden is staggering.
And when we look at the virology, at the actual biological agent causing this immense suffering, there is this strange paradox.
The simplicity of it.
Exactly. It's incredibly lethal. But the culprit itself sounds remarkably simple. Our sources say it's caused by a virus belonging to the genus Lyssavirus from the family Rhabdoviridae.
Yes. Rhabdoviridae comes from the Greek word rhabdos, which means rod.
Because of how it looks.
Right. Under an electron microscope, the rabies virus has a very distinct, highly recognizable bullet shape, and it is an enveloped, single-stranded, negative-sense RNA virus.
Okay, let's break that down for the listener, because negative-sense RNA sounds like heavy technical jargon, but I know it dictates exactly how this virus operates.
It's crucial to how it replicates, yes.
My understanding is that being negative sense means it has a massive logistical hurdle. It can't just slide into a host cell and immediately hijack the ribosomes to print more viruses, right?
Correct.
Its genetic code is essentially written backward. It's the complementary strand.
That is a highly accurate way to look at it. If a standard positive sense RNA virus is like a set of instructions ready to be read by the host cell's machinery, a negative sense RNA virus is just the mold used to make those instructions.
So it cannot be translated directly into proteins.
Exactly.
So it's kind of like showing up to a massive construction site to build an army, but your blueprints are written in reverse. The host cell's workers have no idea what to do with it.
Precisely. And because the host cell doesn't naturally possess the specific machinery to read backward RNA, the rabies virus has to bring its own specialized translator.
It packs its own tools.
It has to. It carries an enzyme called an RNA-dependent RNA polymerase directly inside the viral particle.
So once it gets in,
Once it enters the host cell, it uses this enzyme to transcribe its negative sense genome into readable, positive sense messenger RNA. Only then can the host cell start building the viral proteins.
it's fascinating because its genetic material is incredibly compact. Our sources note it encodes for only 5 specific proteins.
Just 5.
That's an extremely minimalist toolkit for something that causes a 100% fatality rate once symptoms emerge. You literally have 5 proteins against the entire human immune and nervous system.
Yes, 5 proteins. The nucleoprotein, phosphoprotein, matrix protein, glycoprotein, and that viral polymerase we just mentioned. It's a masterclass in biological efficiency.
But the one that really does the heavy
The
lifting,
most critical one for our discussion, the one that defines everything about how this virus moves and kills, is the glycoprotein, or the G protein.
the spikes.
Exactly. These G proteins form little spikes that coat the outer envelope of the virus. They are the keys that the virus uses to pick the locks of the host cells.
But that envelope is also its greatest weakness, isn't it? Because our sources say it's a lipid envelope, meaning it has an outer layer made of fats, stolen from the host cell it originated from,
Right.
which makes the virus incredibly fragile outside of a living body.
Highly fragile. It cannot survive long in the environment. It is rapidly inactivated by sunlight, by ultraviolet irradiation, by heat, by drying out.
So it hates being out in the open.
It really does. And crucially, from a clinical perspective, that lipid envelope is easily destroyed by simple lipid solvents.
Like what?
Soap, detergent, povidone iodine, even alcohol.
Wait, really? So the virus that has terrified humanity for millennia, that essentially has a flawless kill rate once it reaches the brain, can be literally ripped apart by basic dish soap.
It can, because soap molecules are amphiphilic.
Meaning they have two different ends.
Right. They have one end that bonds with water and one end that bonds with fats. They wedge themselves into the virus's lipid envelope, shatter it, and the virus simply falls apart, rendering it completely non-infectious.
Yeah.
It is uniquely vulnerable in the environment. But once it bypasses the external defenses and slips inside the host's tissues, its simplicity and those specialized G protein keys make it devastatingly effective.
Which brings us to the actual mechanics of exposure.
Yeah.
Now that we know what this bullet-shaped virus looks like and how fragile it is in the open air, we need to understand where it lurks.
Right.
Like, how did it breach the 12-year-old boy's defenses? Where does this virus maintain its stronghold when it's not infecting humans?
Rabies is an archetypal zoonotic disease. It is maintained entirely within animal reservoirs and then transmitted to humans.
And globally, the main culprit is the dog.
By far. The primary carrier, the reservoir that drives the absolute vast majority of human infections and deaths, is the domestic dog. When we analyze global epidemiology, dog-mediated rabies accounts for up to 99% of all human rabies transmissions.
Well, 19%.
It's massive. And this is the direct link back to the stray dog in our clinical case with the boy.
So when we talk about the global burden of rabies, we are almost exclusively talking about dog bites. Yet, particularly in North America, we constantly hear warnings about bats.
Yeah, that is due to a geographic shift in epidemiology.
How so?
Well, in regions where canine rabies has been aggressively controlled or largely eliminated through mass dog vaccination programs, places like the United States, Canada, and parts of Western Europe, the primary source of human infection shifts to wildlife reservoirs.
So because we vaccinated the dogs, the bats became the main problem.
Exactly. In the Americas, bat-associated rabies variants are now the leading cause of human rabies deaths. But it's not exclusively bats.
What else carries it?
Raccoons, skunks, and foxes serve as major terrestrial wildlife reservoirs in different geographic corridors.
So how does it physically move from the reservoir to the human? We always focus on bites, but given how the virus is shed, are there other modes of transmission?
The virus is heavily shed in the saliva of the infected animal, so the most common and by far the most efficient mode of transmission is a bite that penetrates the skin.
Injecting the saliva deep in there.
Right, injecting the virus-laden saliva directly into the muscle and subcutaneous tissue. However, transmission can occur, albeit much less frequently, if infected saliva comes into direct contact with an open wound, a fresh scratch, or mucous membranes.
Like your eyes, nose, or mouth.
Exactly.
So like a dog licking an open scrape on your hand could technically infect you.
It absolutely could. There are also incredibly rare documented cases of transmission through aerosolized virus in heavily populated bat caves where the air is just thick with bat guano and secretions.
Oh, wow. I wouldn't want to breathe that in.
Definitely not. Or through organ and corneal transplants from an infected donor who died of undiagnosed rabies. But bites are overwhelmingly the primary route we see in emergency departments.
Okay, so the stray dog bites the boy. But our sources emphasize a really critical clinical concept here. Not all bites are created equal.
Not at all.
The specific location of the bite on the body carries a fundamentally different risk profile. Why does a bite on the hand or face matter so much more than a bite on the calf?
It matters immensely because of the virus's specific mode of transport once it enters the tissue. The rabies virus does not travel through the bloodstream.
Wait, it avoids the blood entirely.
This is a crucial point. If it entered the blood, the body's systemic immune system would detect it relatively quickly and mount a massive defense to clear it. Instead, the rabies virus is strictly neurotropic.
Meaning it targets nerves.
It specifically seeks out nerves. Therefore, the look of a bite is dictated by the depth of the wound, the amount of saliva introduced, and most importantly, the density of nerve endings at the exact site of the bite.
Let me see if I can visualize this. It's not like dropping an invading force onto a highway where the immune system state troopers are constantly patrolling.
I like that analogy.
It's more like the virus finds an entrance to an underground, heavily shielded subway tunnel that leads directly to the capital city, the brain. And the immune system isn't allowed to patrol those tunnels. So if you get bitten on the toe, you've entered a subway station way out in the rural suburbs. It's a long, slow train ride to the city center. But if you get bitten on the face or the neck...
You've entered the subway station right underneath the Capitol building.
Exactly.
That makes so much sense.
A bite to the face, the neck, or the hands areas that are incredibly rich in sensory and motor nerve endings is categorized as a high-risk exposure. The physical distance the virus has to travel to reach the central nervous system is drastically shorter.
And there are more tunnels.
Right. The nerve pathways are numerous and dense. In contrast, a bite on the lower extremity means a much longer transit time. And this concept of transit time is the master key for understanding the 12-year-old patient in the ER.
Right. Because the boy was bitten 2 months ago. For 60 days, he was completely fine. He went to school, he played video games, he ate dinner with his family, completely unaware that a biological time bomb was sticking inside him.
A perfect description. Why did it take exactly 2 months for him to end up in the emergency department?
This brings us to the most insidious phase of the disease, the pathogenesis and what we call the silent commute.
The silent commute.
As we established, the rabies virus exhibits strict neurotropism, but how it actually breaches that nervous system is just a marvel of evolutionary hacking.
Walk us through the how. The dog's tooth breaks the skin on the boy's leg, and virus-laden saliva is deposited into the muscle tissue. What happens in the very first hours and days?
Initially, the virus might replicate very slowly, very locally, within the striated muscle cells near the bite site.
But it's not setting off alarms.
No, because it isn't causing massive tissue destruction, so it largely evades immediate detection. Then those G proteins on the surface of the virus, the keys we discussed earlier, seek out a highly specific target.
Which is?
A nicotinic acetylcholine receptors.
Acetylcholine receptors. Those are the receptors at the neuromuscular junction, right?
That's the spot.
The exact synapse where your nervous system connects to your muscle fibers to tell them to contract.
Yes. The virus targets the very communication bridge between muscle and nerve. The viral G protein binds tightly to these nicotinic acetylcholine receptors, effectively picking the lock, and the virus is internalized into the peripheral nerve terminal.
And once it's inside the nerve cell, it's essentially shielded from the body's main immune patrols.
Completely shielded.
But nerves are long cells. I mean, a nerve running from your leg to your spinal cord can be over a meter long. How does a tiny virus travel that immense cellular distance?
It hijacks the nerve's own internal transport infrastructure. Inside nerve axons, there are long tracts called microtubules.
Like the rails of that subway tunnel.
Exactly like the rails. And nerves have molecular motors, specifically a protein called dynein, that naturally carry essential cellular materials up those tracts toward the cell body.
Oh, I see where this is going.
The rabies virus physically attaches itself to these dynein motors and undergoes what we call retrograde axonal transport.
Retrograde meaning backward. It's moving against the usual flow of traffic, which usually sends signals from the brain down to the muscle.
Yes, it is literally being chauffeured up the nerve axon.
How fast?
Moving steadily at a speed of roughly 12 to 250 millimeters per day, depending on the specific nerve and the viral strain. Day by day, millimeter by millimeter, it travels up the peripheral nerve, into the spinal cord, and straight toward the brain.
I have to admit, I've always struggled with this from an evolutionary perspective. I need to push back on this whole stealth idea.
Okay, let's hear it.
If this virus is 100% fatal once symptomatic, isn't that a terrible long-term survival strategy? Like a parasite that kills its host every single time usually burns itself out quickly because it runs out of bodies to infect.
How has it survived for thousands of years with a kill rate that high?
It's a brilliant question, but it highlights a really common misunderstanding about zoonotic diseases. Your logic assumes humans are the target host.
We aren't.
We aren't. From the rabies virus's perspective, infecting a human is a biological mistake. Humans are what we call a dead-end host.
Meaning we don't naturally pass it on. Right, we don't generally go around biting other humans or animals when we get sick. The virus evolved over millions of years to infect, replicate within, and be transmitted by canines and bats.
Ah, I see.
In those animal populations, the timing of the aggression, the viral shedding in the saliva, and the biting behavior are perfectly synchronized to ensure the virus jumps to a new host just before the current host dies.
Wow.
The fact that it accidentally spills over into a human and kills them with 100% efficiency is just collateral damage to the virus.
That makes perfect sense. It's adapted for a dog's behavior, not ours.
Mm.
So during this long retrograde transport up the boy's leg nerve, this silent commute, he feels nothing.
Absolutely nothing.
How does a virus travel through your body for 2 months without triggering a fever, a rash, anything? I mean, a simple rhinovirus triggers a runny nose and a low-grade fever almost immediately.
The clinical silence is the virus's most terrifying feature. Rabies does not lyse or destroy the nerve cells as it travels through them.
Because if it did,
If it destroyed the nerves, the host's immune system would immediately sense the cellular debris and mount a massive inflammatory response that could halt the virus.
it's too smart for that.
Instead, rabies leaves the nerve cells structurally intact. It quietly rides the dynein motors, keeping the host alive, functional, and completely asymptomatic. It wants to reach the brain undetected. This entire period of the silent commute is what we call the incubation period.
So the incubation period isn't a set number of days. It's highly variable because it's literally a math equation of physical distance divided by transport speed.
Precisely. The incubation period is typically 1 to 3 months, which perfectly aligns with the 2-month gap in our 12-year-old's case.
But it can be faster or slower.
It can range from less than a week, say, if a child suffers severe multiple bites to the head, and phase 2 over a year in very rare documented cases involving bites to the extremities. Yes. It depends on the viral load introduced, the bite location, the specific variant of the virus, and the density of innervation. But during all this time, the patient feels fine. Routine blood tests would show nothing abnormal.
That is deeply unsettling. If you're looking at a healing dog bite on your own leg, the time it takes for that physical wound to close is actually working against you. The virus is moving while you think you're getting better.
Exactly.
And for our patient, that 60-day silent commute is now over. The virus has reached the brain. The tipping point has been crossed. This is where those harrowing symptoms we saw in the ER begin to manifest.
Yes. The moment the virus enters the central nervous system, its behavior changes drastically. It switches from a slow, stealthy commute to explosive replication within the neurons of the brain.
It just takes over.
It does. And from the brain, it initiates what we call centrifugal spread. It travels back out through efferent nerves to highly innervated organs throughout the body, most notably the salivary glands, the skin, and the corneas.
Because it's preparing to be transmitted to the next host.
Exactly. Loading the salivary glands is the ultimate goal. And this massive replication in the brain and subsequent centrifugal spread marks the abrupt end of the incubation period and the beginning of the clinical stages of rabies.
So how does the clinical picture unfold? Like, how does this boy go from perfectly healthy to hyperventilating and terrified of water?
It begins with the prodromal phase. This is the initial onset of clinical symptoms, and tragically, they are entirely nonspecific.
Like flu symptoms.
Exactly. The patient presents with fever, malaise, headache, gastrointestinal distress. It looks exactly like a severe viral flu. But there is one telltale clinical sign that occurs in a significant portion of patients during this prodrome.
What's that?
Neuropathic pain, intense itching, paresthesia, or burning sensation localized exactly at the site of the long-healed bite wound.
Oh, wow. So the dog bite on his leg, which healed 2 months ago, suddenly starts burning and itching intensely. Why? Because the virus is now in the brain, sending erratic damage signals back down the nerve highway to the point of entry.
That's right. The dorsal root ganglia are inflamed, and the sensory nerves are misfiring. But this prodromal phase is fleeting, usually lasting only 2 to 10 days.
And then what?
From there, the disease fractures into one of 2 distinct clinical presentations. Furious rabies, which accounts for about 80% of human cases, or paralytic rabies, also known as dumb rabies, which makes up the remaining 20%.
Based on the ER description, the agitation, the darting eyes, the panic, our patient clearly falls under the furious rabies category.
Yes, his presentation is classic furious rabies. This form is characterized by profound, acute neurological manifestations.
What does that look like medically?
Patients experience hyperactivity, fluctuating levels of consciousness, so they might be lucid one moment and hallucinating the next, along with extreme agitation, confusion, and autonomic dysfunction like excessive sweating, dilated pupils, and hypersalivation.
The brain is just short-circuiting.
The virus is causing severe encephalitis, functionally destroying the brain's ability to regulate emotion, physical movement, and autonomic control.
Okay, here is where we have to unpack the most famous and undoubtedly the most disturbing symptom associated with rabies.
Hydrophobia.
Hydrophobia, the fear of water. We said our patient violently pushes a cup of water away and gags. What is the actual physiological why behind hydrophobia? You said earlier that human infection is a dead-end mistake, but from the virus's perspective in a canine host, why does it care if the host drinks water?
If we look at this purely through the lens of viral survival, hydrophobia is an incredibly dark evolutionary masterpiece.
Really? How?
Well, to successfully transmit to a new host, the rabies virus needs the current host to bite another animal, and it needs that bite to be heavily loaded with virus-rich saliva.
So it needs to maximize the concentration of virus in the mouth.
Right.
If the host drinks water, they swallow the saliva, washing the virus down into the stomach acid where it's destroyed.
Precisely. The virus actively prevents the host from swallowing. It specifically targets and inflames areas of the brainstem, particularly the nucleus ambiguus, which controls the complex motor coordination required for swallowing and breathing.
So it physically blocks swallowing.
When the patient attempts to drink, or sometimes even just thinks about drinking or sees water, the brainstem misfires catastrophically. This triggers violent, excruciatingly painful, involuntary spasms of the pharyngeal and laryngeal muscles.
So they become terrified of water because trying to swallow it feels like they are literally choking to death.
Yes, it is a profound physiological aversion driven by intense pain and the feeling of asphyxiation. It's not a psychological hatred of the liquid itself, it's a learned terror of the physical reflex.
That is horrifying.
And because they absolutely cannot swallow, their saliva begins to pool in their mouth. They begin to drool profusely. That saliva is now teeming with millions of viral particles that have traveled down from the brain.
Oh, that perfectly explains the classic image of the rabid animal foaming at the mouth.
Exactly. The foaming is simply pooled, highly infectious saliva that is being agitated by the animal's rapid breathing and mouth movements.
So the host is basically a loaded weapon.
Combine that pooled saliva with the severe agitation, the hallucinations, and the aggression caused by the brain inflammation, and you have a host that is perfectly primed neurologically and physically to bite and transmit the virus.
Is there anything else like hydrophobia?
There is also a closely related symptom called aerophobia, where even a slight draft of air blowing across the patient's face can trigger the exact same violent throat and diaphragm spasms.
From just air.
It's a localized hyperreflexia. The sensory input from the air current overloads the damaged brainstem pathways.
You mentioned earlier that 20% of cases are paralytic rabies. What does that look like? If an animal have that form, it's not going to be aggressively biting people.
No, it won't. Paralytic rabies is less dramatic in its presentation, but equally fatal. Instead of hyperactivity and aggression, the patient experiences a flaccid muscle paralysis that usually begins at the site of the bite and gradually, progressively ascends, spreading throughout the entire body.
Ascending paralysis. That sounds like Guillain-Barré.
It very closely mimics it and is often misdiagnosed as Guillain-Barré syndrome. Eventually, the paralysis reaches the respiratory muscles, leading to respiratory failure, coma, and death.
But for a 12-year-old boy, the presentation is furious rabies.
Right.
So seeing this boy in the ER with the agitation, the hypersalivation, the intense throat spasms when offered water, and the history of a dog bite 2 months prior.
Yeah.
I mean, to us, analyzing the case retrospectively, the clinical picture seems glaringly obvious.
In hindsight, yes.
But medical professionals in the moment need certainty. You can't just guess when a life is on the line. How is rabies actually diagnosed in a clinical setting when the patient is right in front of you?
It is notoriously incredibly challenging. The antemortem diagnosis, meaning confirming the diagnosis while the patient is still alive, is difficult.
Why is it so hard?
The differential diagnosis for a patient presenting with severe acute encephalitis, altered mental status, and muscle spasms is vast. Furthermore, patients or their families often forget or fail to mention a minor animal bite that occurred months ago.
Right. If a scratch healed in 3 days, you aren't thinking about it 60 days later when your child is hallucinating. What else are physicians considering when a patient presents like this?
They have to consider other viral encephalitides, most notably herpes simplex virus or HSV encephalitis, which can also cause bizarre behavior and focal neurological signs.
What about bacterial infections?
They have to consider infectious diseases like severe tetanus. Tetanus also causes severe, painful muscle spasms, often starting with trismus or lockjaw, due to a toxin affecting the nervous system, though tetanus doesn't typically cause the severe altered sensorium seen in rabies.
Any non-infectious causes?
Physicians also have to rule out psychiatric emergencies, acute drug toxicities, and autoimmune cephalitides, where the body's own immune system attacks the brain.
Is the ultimate tragedy here that by the time the clinical picture is clear enough, specific enough to warrant a targeted rabies workup, it's already too late? Like, the early prodromal symptoms, fever, headache, are just too vague to trigger a massive, specialized diagnostic protocol.
That is the exact sobering clinical reality. By the time a physician suspects rabies and orders the specific diagnostic assays, the virus has already overwhelmingly infiltrated the central nervous system.
And there's no quick test.
No, complicating matters, there is no single rapid test that can definitively rule out rabies while the patient is alive. To get a reliable antemortem diagnosis, you need a combination of multiple tests across different fluid and tissue samples.
What exactly are we looking for in the lab? Are we looking for the physical virus particle, or are we looking for the body's immune response, the antibodies?
We look for both, but the timeline dictates what we will actually find. We can test the patient's saliva using reverse transcription polymerase chain reaction, or RT-PCR, to detect the specific viral RNA.
Because it sheds into the saliva.
Because the virus sheds centrifugally into the salivary glands, PCR on serial saliva samples can be highly sensitive. We also perform a very specific skin biopsy from the nape of the neck, the nuchal area.
Why the back of the neck specifically?
We take a full-thickness punch biopsy of the skin there because we want to examine the hair follicles. The base of the hair follicles is highly innervated with sensory nerves.
Looking for the virus in the nerves.
Exactly. We use a technique called direct fluorescent antibody testing to look for the physical presence of the viral antigen right inside those cutaneous nerves.
What about a spinal tap? In almost any case of suspected brain inflammation, you do a lumbar puncture to examine the cerebrospinal fluid, the CSF. What does rabies look like in the CSF?
We absolutely analyze the CSF primarily to rule out other causes like bacterial meningitis. But in rabies, the routine CSF analysis is often surprisingly unremarkable.
Really?
You might see a mild pleocytosis, a slight elevation in white blood cells, predominantly lymphocytes, indicating a viral process, and slightly elevated protein. But the key is looking for rabies-specific antibodies in both the serum and the CSF.
But didn't you say earlier that the virus hides inside the nerves during its commute? The immune system doesn't even know it's there?
Exactly, and that is a crucial diagnostic pitfall. Because the virus remains sequestered in the immunologically privileged nervous system for so long, serum neutralizing antibodies might not appear until very late in the disease process, often not until after the patient has been symptomatic for a week or more.
Oh, wow.
And antibodies in the CSF appear even later.
So a negative rabies antibody test early in the hospitalization absolutely does not mean they don't have rabies.
Correct. It simply means their immune system hasn't mounted a systemic response yet.
What about an MRI?
As for imaging, an MRI of the brain might be ordered, but the findings are often nonspecific. You might see hyperintense signal abnormalities on T2-weighted images in the brainstem, thalamus, or spinal cord, but it's not definitively diagnostic of rabies. Historically, and unfortunately still in many parts of the developing world, the definitive gold standard diagnosis remains postmortem.
Meaning they can only be 100% sure after the patient has passed away.
Yes. After death, brain tissue is examined pathologically. Specifically, pathologists look for Negri bodies.
Negri bodies. I remember the sources spending a lot of time on those.
They are distinct eosinophilic cytoplasmic inclusions found inside infected neurons, particularly in the Purkinje cells of the cerebellum and the pyramidal cells of the hippocampus.
They are essentially little clumps of viral factories, right? Massive aggregates of viral nucleocapsids assembling inside the brain cells. It's heartbreaking because, as you said, the diagnosis at that point just confirms the inevitable.
It does, which is why the single most critical aspect of rabies management does not happen in an intensive care unit. It happens 2 months prior, immediately after the bite occurs.
And this leads us to what is arguably the most important section of this entire deep dive for the listener, the window of opportunity. The most agonizing, frustrating aspect of this 12-year-old boy's case is what didn't happen 2 months ago.
It's a preventable tragedy.
The medical sources are absolutely emphatic on this point. Rabies is almost 100% fatal once clinical symptoms appear, but it is nearly 100% preventable beforehand. Let's detail post-exposure prophylaxis, or PEP.
Post-exposure prophylaxis is one of the most remarkable and successful medical interventions in human history, provided it is administered promptly.
How does it work?
It relies entirely on the unique pathogenesis we discussed. The fact that the rabies virus has a long, slow incubation period. Because it takes weeks or months to commute up the peripheral nerve to the brain, we are granted a physiological window of time.
A chance to fight back.
Yes, we can train the host's immune system to intercept and destroy the virus while it's still traveling.
Okay, let's break down the exact steps of PEP. Let's say a listener is bitten by an unknown stray dog tomorrow. What is the very first thing they must do?
Step 1, immediately before you even get in the car to go to the hospital, is aggressive wound management. As we discussed, the rabies virus has a fragile lipid envelope.
The soap vulnerability.
Yes. Thorough washing and rigorous flushing of the wound for a minimum of 15 minutes with soap, water, and a virucidal agent like povidone iodine is the single most effective way to mechanically wash out and chemically destroy the virus right at the site of entry.
15 minutes is a long time to wash a wound.
This cannot be overstated. Vigorous washing alone significantly reduces the risk of the virus ever entering the nerve.
So you wash the wound like your life depends on it, because it literally does.
Yeah.
But washing alone isn't a guarantee. You still have to go to an emergency department or clinic.
Absolutely. Once at a healthcare facility, the medical team will evaluate the exposure risk. Was it a provoked bite? What type of animal? What is the local epidemiology? And likely initiate the next two critical systemic components of PEP. Rabies immunoglobulin, or RIG, and the rabies vaccine series.
Let me try an analogy here to visualize how these two work together. Let's say the virus is a squadron of enemy bombers trying to target the nerve endings. The RIG of the immunoglobulin is like dropping a massive cloud of chaff from a fighter jet right over the battlefield.
Okay, I see where you're going.
It's a swarm of decoy targets that instantly binds up the virus's G proteins. The virus physically cannot insert its keys into the nerve's locks because the keys are gunked up by the chaff. It provides instant, localized protection, buying time for the actual anti-aircraft radar system, the vaccine, to be built and brought online.
That is an excellent way to visualize the mechanism. Rabies immunoglobulin provides passive immunity. It consists of pre-made, highly concentrated antibodies against the rabies virus, usually harvested from human donors who have been hyperimmunized.
How is it given?
We literally infiltrate or inject the RIG directly into and around the margins of the bite wound as much as physically possible, using whatever is left over for an intramuscular injection at a distant site.
Right into the wound itself. Ouch.
It's painful, but necessary. The goal is exactly as you described. Immediate localized neutralization of the viral particles present in the tissue before they can bind to those nicotinic acetylcholine receptors. It's the chaff blinding the bombers.
And the vaccine.
The vaccine provides active immunity. It is a series of shots given in the deltoid muscle of the arm, never in the gluteal muscle, as absorption there is poor. Modern schedules usually involve 4 doses given on days 0, 3, 7, and 14.
What's in the vaccine?
The vaccine contains inactivated rabies virus. It is essentially showing the immune system the blueprints of the enemy. By the time the passively administered RIG starts to naturally degrade and clear from the body, the vaccine has stimulated the patient's own immune system to produce a massive systemic army of its own neutralizing antibodies.
There's a handoff.
Together, the immediate RIG and the long-lasting vaccine ensure that the virus is hunted down and destroyed before it finishes its silent commute to the CNS.
Now, I read in the sources that people who work constantly with animals, like veterinarians or wildlife biologists, get a vaccine beforehand. Pre-exposure prophylaxis or pre-P.
Yes. Pre-P involves receiving a series of vaccine doses before any known exposure occurs. It trains the immune system in advance.
Does that mean they're immune forever?
No, it's important to note that Pro-P does not completely eliminate the need for medical evaluation if a high-risk bite happens, but it drastically simplifies the response. If someone with prior Pre-P is bitten, their immune system is already primed.
So they don't need the RIG.
They do not need the painful and expensive RIG injections around the wound, and they only need 2 booster doses of the vaccine, usually on days 0 and 3, rather than the full series. It is an essential safeguard for laboratory workers, veterinarians, and individuals traveling to remote high-risk areas where immediate access to RIG might be impossible.
But for the 12-year-old patient in our case study, he had no pre-P. And crucially, because the bite was ignored, he received 0 PP. The window of opportunity closed.
It did. And now, in the intensive care unit, the levee has broken. He is fully symptomatic. The virus is actively destroying his brainstem function. The immediate neutralizing antibodies were never administered. His long-term immune guards were never trained.
What, if anything, can modern medicine do for this boy right now? I mean, we have incredible antiviral drugs for things like HIV and hepatitis C. Can we give him antivirals?
Historically and tragically still, in the vast majority of cases today, the management of symptomatic rabies is strictly palliative.
So just keeping him comfortable.
It is about providing comfort and dignity. The focus shifts entirely to deep sedation, profound analgesia, and managing the terrifying symptoms. Physicians use heavy doses of sedatives to calm the intense agitation, paralytics or anticonvulsants to stop the horrific muscle spasms, and keep the patient in a quiet, dark room to minimize any sensory stimuli that could trigger aerophobia or hydrophobia.
It's essentially just easing their passing. But our sources do detail one highly controversial, aggressive intervention, the Milwaukee Protocol. What exactly is that?
The Milwaukee Protocol represents a desperate experimental attempt to cure symptomatic rabies. It was developed in 2004 by Dr. Rodney Willoughby, a pediatric infectious disease specialist, when he treated a 15-year-old girl named Gina Geese in Milwaukee, Wisconsin.
She'd been bitten by a bat, right?
Yes. She had been bitten by a bat, did not receive PEP, and developed clinical furious rabies.
And she survived. She is historically famous for being the first unvaccinated person to ever survive clinical rabies. How did they achieve that?
The rationale behind the protocol was based on a specific observation about the pathology of rabies. As we mentioned, the virus doesn't cause massive structural damage, necrosis, or cellular death in the brain initially.
Right, doesn't mobilize the cells.
Instead, it causes severe functional failure. It alters neurotransmitter function, specifically leading to massive glutamate excitotoxicity.
Excitotoxicity, meaning the excitatory signals in the brain are dialed up to 11 and the inhibitory signals are blocked.
Exactly. The brain cells are essentially overstimulated to the point of exhaustion and failure. They overfire until the autonomic system shuts down. Dr. Willoughby theorized that if they could medically induce a profound therapeutic coma, they could protect the brain from this excitotoxicity.
Just put the brain on pause.
They could essentially turn off the lights, quiet the brain's activity, and put the neurons to sleep, giving the girl's own native immune system enough time to finally recognize the virus, ramp up antibody production, and clear the infection from the CNS.
So they put her in a chemically induced deep coma and pumped her full of antiviral drugs.
Yes. They used a combination of anesthetics, primarily ketamine, which is an NMDA receptor antagonist thought to help block the excitotoxicity, along with midazolam. They also administered antivirals like ribavirin and amantadine.
And it worked.
Astonishingly, after weeks in a coma, her immune system cleared the virus. She woke up. She had profound neurological deficits and had to spend months relearning how to walk and talk, but she survived.
That sounds like a miraculous medical breakthrough. So why do the sources say it's highly controversial? If it worked for her, why isn't it the gold standard for every rabies patient?
That is the exact heated debate that has raged in the infectious disease community for 2 decades. The controversy stems from a profound, tragic failure to replicate that initial success.
Other doctors tried it?
Following Gina Geese's highly publicized survival, variations of the Milwaukee Protocol were attempted dozens, perhaps hundreds of times worldwide on other symptomatic rabies patients.
And the results?
The overwhelming majority of them died. The survival rate remained agonizingly close to 0.
Oh, so it wasn't a universal cure at all.
Not at all. And critics of the protocol point to several massive scientific and clinical issues. First, they argue that the specific antivirals used, like ribavirin, have no proven in vitro efficacy against the rabies virus. And ketamine coma carries massive inherent ICU risks, including secondary infections and cardiovascular collapse.
That makes sense. A long coma is dangerous.
But the most significant point of contention, the real scientific mystery, revolves around survivorship bias and the specific genetic variant of the virus.
What do you mean by variant? Does it fundamentally matter what type of animal bit you?
It appears it matters immensely. When researchers analyzed the incredibly rare handful of patients who have survived clinical rabies, including Gina Geese, almost all of them were infected with bat-associated variants of the virus, specifically variants from the New World.
Wait, really?
None of the well-documented survivors were infected with the classic, highly virulent dog-mediated variants that cause the massive global death toll.
Are you saying she might have survived despite the intensive protocol, not because of it? That her specific immune system, combined with a slightly weaker or less neurovirulent bat virus, allowed her to pull through while the doctors just happened to have her in a coma?
That is exactly the prevailing theory among many leading infectious disease and rabies experts today. They argue that bat variants might occasionally be less virulent in humans, allowing a naturally robust immune response a tiny fraction of a chance to clear it.
So the protocol itself might be useless against a dog bite.
They argue that the Milwaukee Protocol is not a replicable cure, and that heavily promoting it diverts immense critical medical resources, ICU beds, nursing staff, hundreds of thousands of dollars away from proven humane palliative care, while simultaneously giving devastated families cruel, false hope. Today, the vast majority of international medical guidelines do not recommend the Milwaukee Protocol.
So to bring it back to the heartbreaking reality of our 12-year-old boy, who was bitten by a stray dog and is now showing advanced symptoms of furious rabies. His prognosis remains incredibly grim.
It is essentially fatal. Once those severe clinical signs emerge indicating massive viral replication in the brainstem, the physiological levee has broken. The viral load is unsurvivable.
It's devastating. Stepping back from the clinical tragedy in the ER, how do we prevent this on a global scale? We know that human post-exposure prophylaxis works flawlessly, but PE is inherently a reactive measure.
Yeah.
You're waiting for someone to get bitten. What is the bigger picture for public health?
The bigger picture requires a massive paradigm shift toward a One Health approach. One Health is a collaborative, global framework that recognizes the deep, inextricable interconnection between human health, animal health, and the shared environment.
Meaning you can't just treat the humans.
Because humans are dead-end hosts, because we don't naturally sustain the viral transmission cycle, the most logical, most effective way to eliminate human rabies is to eliminate the threat at the source.
The animal reservoir.
Given what we know about animal reservoirs, specifically that domestic dogs cause 99% of human cases, how close are we actually to eliminating dog-mediated rabies globally? And what are the main roadblocks standing in our way?
From a purely scientific and biological standpoint, it is entirely feasible. The World Health Organization, along with several global partners, has an initiative called 0 by 30. The goal is 0 human deaths from dog-mediated rabies by the year 2030.
How do they plan to do that?
The primary, most effective strategy to achieve this is mass dog vaccination.
Herd immunity for the dogs. Exactly. Epidemiological models show that if you consistently vaccinate 70% of the dog population in a given geographic region, you create a threshold of herd immunity. The virus can no longer find enough susceptible canine hosts to sustain its transmission cycle, the chain of infection breaks, and the virus naturally dies out in that area.
That seems so much more efficient and, frankly, so much more humane than trying to ensure you can get highly expensive human PP to every single person in a remote village who gets bitten.
It is far more effective, and economically the disparity is staggering. A single dose of a high-quality canine rabies vaccine costs mere pennies. Conversely, a full course of human PP, including the highly specialized rabies immunoglobulin and multiple doses of cell culture vaccine, can cost hundreds or even thousands of dollars.
Which is a massive burden.
It places a massive economic burden on healthcare systems in developing nations. By vaccinating the dogs, you build an impenetrable barrier of immunity between the virus and the human population.
If the math is that clear, what are the roadblocks?
The roadblocks are almost entirely logistical, political, and economic. The challenges lie in securing consistent long-term funding in developing nations, organizing campaigns to reach massive populations of free-roaming, unowned stray dogs, and maintaining strict surveillance to prevent the virus from being reintroduced from neighboring regions.
But it works when people try it.
The proof of concept is undeniable. Where mass dog vaccination has been implemented rigorously, it works spectacularly. Latin America, through aggressive, sustained, government-backed dog vaccination campaigns, has reduced human rabies cases by over 95% in the last few decades.
That is a phenomenal public health victory and a blueprint for the rest of the world. Okay, before we wrap up, I want to make sure we hit some of the specific misconceptions and high-yield clinical pearls that our sources laid out. There's a lot of mythology around rabies in pop culture. Let's do a rapid-fire debunking.
Let's do it.
Myth number 1. Rabid animals are always hyper-aggressive, vicious, and foaming at the mouth.
False. While the furious form of rabies certainly causes aggression, we must remember the paralytic or dumb form. An infected animal with paralytic rabies might just seem unusually tame, profoundly lethargic, or partially paralyzed.
So a friendly raccoon is a bad sign.
A wild animal, like a raccoon or a fox, that has lost its natural fear of humans and allows you to approach it should be considered a massive red flag for rabies.
Myth number 2. Hydrophobia means the infected person literally hates water, or is psychologically or spiritually repelled by the substance itself.
False, as we discussed in detail. It is a severe physiological reflex. The patients are often desperately thirsty, but the physical act of swallowing triggers excruciating, suffocating diaphragmatic and laryngeal spasms. It is a learned, terrified anticipation of the physical pain of swallowing, not a psychological aversion to water itself.
Okay, what about clinical pearls, specifically for the healthcare professionals or medical students listening to this deep dive? What are the high-yield, actionable takeaways they need to remember at the bedside?
The most critical, counterintuitive pearl for wound management. Never close a high-risk animal bite wound tightly with primary sutures.
Wait, really? Why not? If someone comes in with a massive gaping laceration from a dog bite, your instinct as a clinician is to clean it and stitch it up to stop bleeding and prevent scarring.
You must resist that instinct. Suturing a wound closed can actually trap the rabies virus deeply within the tissue. Worse, passing a suture needle through the tissue can physically inoculate the virus deeper, piercing intact nerve endings and creating a direct superhighway for the virus to enter the peripheral nervous system.
Wow, so you're actually helping the virus.
You are. Furthermore, closing the wound creates an anaerobic environment that fosters secondary bacterial infections, and it prevents the wound from freely draining. You want the wound to remain open so you can vigorously, continuously irrigate it.
So what do you do if the laceration is on the face and cosmetically devastating?
If sutures are absolutely anatomically or cosmetically necessary, they should be placed loosely to allow for drainage. But most importantly, the full calculated dose of rabies immunoglobulin must be meticulously injected directly into the wound margins and the deep tissue bed before any needle or suture passes through the tissue.
That makes perfect sense given the lipid envelope vulnerability and the need to neutralize the virus locally. Is there another pearl?
Yes, the bat in the bedroom rule. This is a vital public health guideline, particularly in North America. Bat teeth are incredibly tiny, like hypodermic needles. A bat bite might not leave a visible mark, and you might not even feel it if you are deeply asleep.
That's terrifying.
Therefore, if a person wakes up to find a bat in their bedroom, or if a bat is discovered in a room with an unattended infant, an intoxicated person, or someone who is cognitively impaired, it must be considered an exposure.
Even if there is absolutely no visible scratch or bite mark on their body?
Even without a visible mark. Because the risk of the disease is a 100% fatality rate, and the consequence is so absolute, you cannot safely assume they weren't bitten. You err on the side of caution, and full post-exposure prophylaxis is indicated.
This has been an incredibly heavy, dense, but deeply necessary dive. We've traced this ancient, bullet-shaped virus from a seemingly minor stray dog's bite through a mathematically precise, silent 2-month commute up the peripheral nerves to a devastating, unstoppable neurological climax.
It really is a terrifying journey.
The take-home messages for you listening are absolute. The immediate, vigorous washing of any animal bite with soap and water can quite literally save your life by destroying the viral envelope. And timely post-exposure prophylaxis, the combination of neutralizing chaff and the active vaccine, is a marvel of modern medicine that stops an otherwise 100% fatal disease dead in its tracks.
And beyond the individual patient, we must remember the broader global perspective. Our 12-year-old patient represents a tragic systemic failure of public health. His case is a glaring reminder of the urgent need for accessible wound care education, availability of PEP in rural areas, and ultimately, the critical importance of funding and executing mass dog vaccination programs worldwide. The profound tragedy of rabies is not just its lethality, it is its near total preventability.
As we sign off, I want to leave you with one final fascinating concept to mull over, something that flips this entire dark narrative on its head. We have spent this entire deep dive discussing the terrifying evolutionary efficiency of rabies neurotropism. We discuss how perfectly it picks the lock at the neuromuscular junction and how it hijacks the nerve's internal dyning motors to travel directly into the brain, completely bypassing the blood-brain barrier.
Yeah, its stealth is unmatched.
But in the cutting-edge world of modern medicine, could this exact mechanism be our greatest future asset? The blood-brain barrier is notoriously difficult to penetrate. It prevents us from delivering life-saving medications to the brain.
It's a huge hurdle in pharmacology.
Right. Well, scientists are currently researching ways to reverse engineer and essentially defang the rabies virus. If we can strip out the lethal RNA that causes the encephalitis, but keep that perfect outer G protein lockpick, Could its retrograde axonal transport system be hijacked by us?
To deliver medicine.
Exactly. Could we use the empty shell of the rabies virus as a microscopic delivery truck to transport life-saving gene therapies or delicate medications directly up the nerve pathways, slipping past the blood-brain barrier to cure neurodegenerative diseases like Alzheimer's, ALS, or Parkinson's?
That is a wild, hopeful thought.
Isn't it? The ultimate killer? The virus that has haunted humanity's nightmares for 4,000 years might one day hold the biological key to the ultimate cure. Thank you for joining us on this deep dive. We'll see you on the next one.